Now we shift focus to the lower chamber of the heart. If you look at the lower chamber of the heart, then there are two lower chambers, the ventricles. So any rhythm that is coming independently from the ventricles will be called as ventricular premature complex. So if you have extra beats coming from the lower chambers of the heart, they are called PVCs or premature ventricular complexes. If they are organized and very fast, they're together, then it becomes ventricular tachycardia. If it is very, very fast, then we call it ventricular fibrillation. So the difference between these two is just a rate. They're both fast. Tachycardia means fast heartbeat. Ventricular tachycardia means coming from the ventricle. If it's at atrial tachycardia, that means it's coming from the atrium. So this is showing you an example of where a patient has sinus rhythm and then gets a wide complex beat which is not preceded by a P wave. You have a wide complex beat which is not preceded by the P wave. It is referred to as premature ventricular complex. Now, when you get a wide complex beat in the middle of and between a sinus beat, then there are a few possibilities. Most likely it is coming from the ventricles, but it is also possible that the wide complex beat is actually coming from the upper chamber of the heart. And why would it be wide? Because when it tries to conduct through the conduction system, it blocks one of the bundles. Either it blocks the right bundle or the left bundle. If it blocks, then the QRS complex will be wide. But that is not necessarily coming from the ventricle. It is actually coming from the atrium in all of these things that I showed you earlier, and just blocking in one of the bundles. So when we see a wide complex beat, we really have to prove whether it is ventricular tachycardia or it is supraventricular tachycardia with a bundle branch block. It's a block, and this is also referred to as aberrancy. Supraventricular tachycardia with aberrancy. So the differential diagnosis of wide complex tachycardia then becomes, number one is always ventricular tachycardia, which means it's coming from the ventricles. Number two is supraventricular tachycardia with aberration or bundle branch block. Number three is pre-excited tachycardia, because I showed you when you had WPW syndrome, you have a tissue that can conduct very fast. And if you see fast, irregular tachycardia, this is usually irregular, very fast, and seen in young patients. If you see a young person coming to the emergency room with wide complex, irregular tachycardia, you should think of WPW. If they are stable, look at their old EKG. If you look at the old EKG, you will see a short PR interval, a delta wave, and a wide QRS. Once you see that, you make a diagnosis that you have WPW, and now what you're seeing is pre-excited tachycardia. The other two things that can cause wide complex is pacemaker-mediated tachycardia. Somebody has a pacemaker in the lower chamber of the heart, it always activates the ventricle with a wide complex. So that tachycardia will be a wide complex tachycardia. And lastly, an important thing to remember, just like people can switch leads, there can be artifact recorded on the ECG. And that can be recorded because the patient is moving, the patient is trembling, patient is having Parkinsonism and has tremors, or there is some noise, electromagnetic noise in nearby, which is being picked up by the 12-lead ECG machine. And so that appears as if the patient is going in wide complex tachycardia, but in real time, what is happening is they have normal sinus rhythm, and the noise is coming in and causing the impression that there is wide complex tachycardia. So you really have to prove this by certain maneuvers. So there are different ways to prove wide complex tachycardia. There are different algorithms. This is one of the criteria that I've given you over here, which is called the AVR criteria. And you have a reference attached to that. So in the interest of time, I won't go into the details of that, but they have a stepwise approach in a patient with wide complex tachycardia that can be used to differentiate it from ventricular tachycardia or supraventricular tachycardia with aberrancy. And so again, I have the reference here, which I would be useful for you to read and to use. The last part is looking at slow rhythms coming from the AV node. So we looked at slow rhythms coming from the sinus node, which were called as sinus pauses. The slow rhythms that come from the AV node can be a very long PR interval, so long conduction time between the atrium and the ventricle, which is more than 200 milliseconds. So if it's just prolonged, we call it first degree AV block. It has to be more than 200 milliseconds. That's the criteria. If it is prolonged and also there is a block between the P wave and the QRS complex, then you have to see whether the block is happening in a regular manner or an irregular manner. If the PR interval is slowly prolonging and then blocking, we call it type 1 second degree AV block or Wenckebach AV block. So there's PR prolongation slowly and then block. That is called Wenckebach. If the PR interval is constant and then there is a block between the upper and lower chambers, that is called type 2 second degree AV block. Type 1 second degree AV block usually happens in the AV node, is not an indication for a pacemaker. Type 2 happens below the AV node and is an absolute indication for a pacemaker. And then the last thing, you can have complete block between the upper and lower chamber of the heart. So in other words, the upper chamber is beating at a much faster rhythm and the lower chamber is beating at a slower rhythm, which has no relationship with the upper chamber rhythm. So this is called third degree AV block. And that means there are more P waves than the QRS complexes that are going through. This slide, I'm just showing you an algorithm, another algorithm to approach patient with wide complex tachycardia, which is again, it is directed at proving dissociation between the atrium and the ventricle. And this would go along with the wide complex tachycardia algorithm that I showed you. Basically, you try to show dissociation between the atrium and ventricle, which means if you show that the atrium is marching slower, then the QRSs are coming from the ventricle. And then there are different criteria based on morphology and in precordial leads, which is the Brugada pattern, Brugada criteria, or right and left bundle branch block morphologies in precordial leads. And then finally, the criteria that I showed you, which is coming from AVR. So this is just showing you an example of what we call AV dissociation, where the P waves are marching slower than the QRS complexes. If you show this in a wide complex tachycardia, you prove that the QRS complexes are coming from the ventricle, and this is ventricular tachycardia. Similarly, if you have a wide complex tachycardia going on and you show a narrow complex beat in the middle of wide complex tachycardia, you again prove that the wide complex is coming from the ventricle and the narrow complex was just normal beats, sinus beats coming through the AV node and capturing the ventricle, causing it to be narrow.